Welcome. Today we are going to learn how to perform close reduction for fracture of both bones forearm in the middle third with apex volar deformity. A 12-year-old boy presented with history of fall on an outstretched hand while playing, and he presented with pain, deformity, swelling and inability to move his limb. On examination, we noticed an S-shaped deformity in the middle of the forearm which was angulated volarly. Here you can see in the clinical photograph as well. An X-ray was ordered, an AP lateral view of the forearm. Here a fracture of both bones forearm in the middle third was identified, and on close inspection on the lateral view we can appreciate that the fracture is angulated volarly. The apex of the fracture is angulated volarly. Hence this fracture is having an apex volar deformity, and usually it happens as a result of a supination injury. Now I shall demonstrate the reduction technique for the same. Now in order to do the close reduction for this apex volar deformity, I would require plaster of Paris bandages, 4-inch 3 number, 6-inch 2 in number and a cotton roll. This is a 6-inch cotton roll which I will cut into half. Now the child has been placed, and I am just grabbing the forearm with my right hand and gently pronating the fracture. This is the most important step in the reduction of this apex volar deformity, that we have to just give a gentle traction and pronate the forearm. This is it, and this will reduce the fracture. Now as we can see that once this has happened, I'm just giving a gentle traction. I'm seeing from the side, and as you can see that the deformity has disappeared. Now what we'll do is we'll take AP and lateral radiographs before applying the POP cast. Here the C-arm has been brought to get an X-ray on the AP, and this is the AP X-ray that we have got, and this I was happy with the reduction in the AP view. Now I'll check for the lateral view, and in the lateral view as well the X-ray is acceptable. So once I am confident about the reduction, we are cleaning the forearm with some spirit and drying it out with a piece of cotton. Now the first thing that I'll apply, my assistants are, you can see that the deformity has disappeared, the S-shaped deformity has disappeared once we see the forearm from the side. The first thing that will be applied will be the layer of cotton, and I use this soft roll, and the cotton is tightly wrapped around the forearm. As you can see, I usually tend to apply this cotton roll in at least 2 layers so as to make the cast comfortable for the child. Now once this cotton has been applied, the first thing that will be done will be a 4-inch plaster of Paris bandage will be dipped in water, and then a little bit of plaster will be squeezed, and the plaster of Paris bandage will be wrapped around the forearm in a circular manner, as you can see in the video graph. The idea about casting a fracture of forearm into pediatric age group is that the cast should be evenly spread, and you have to take care that there should be no wrinkles or folds of plaster. That is unacceptable. So the second POP bandage, this is the 4-inch POP bandage that I'm dipping in water, squeezing some of the plaster, and then applying it over the forearm of the child. So again, the aim would be quickly wrapping the forearm bandage across and trying to evenly spread the plaster over the forearm. Now once this second layer of plaster has been applied, I do the molding part of this. This is the most important step, I believe, in the pediatric age group. And before this, we have to make this. This is the flattening of the cast. I say that we have to change the shape of the cast from a circular into a more of an oval shaped. So this is just by applying an anteroposterior pressure over the cast. The principles of a good forearm casting technique include this intraosseous molding that I am doing. Supracondylar molding will be once I'll do the above elbow part. Appropriate padding that I have already shown. Evenly distributed cast material. A straight ulnar border and 3-point molding. Chess et al. Gave the idea of cast index, in which he defined the cast index as the ratio of the sagittal cast width divided by the coronal cast width at the level of fracture, and he considered it to be around the number 0.70. So the cast index embodies the sound concept of good intraosseous molding. So this is the third layer of plaster that I'm applying over the forearm, and so the 3 POP bandages of 4 inch I have applied over the forearm. So once this third bandage has been applied, I will take a C-arm image and I'll verify my reduction again before I convert it into an above elbow POP cast. So we'll take another C-arm view. So this is the AP X-ray of the forearm, and I'm happy about it. It is acceptable. Now I'll take a lateral view of the forearm at the same level, and here, as you can see, the lateral view of the forearm is also acceptable. Now we will convert this below elbow POP cast into an above elbow one. The position of the cast to be held, the classical teaching in the middle third fractures would be a mid-prone position. So before we convert it into an above elbow cast, the arm is thoroughly cleaned and cotton is wrapped around the arm and elbow of the patient. As you can see, the elbow will be bent at an angle of around 90 degrees with the forearm in mid-prone position. So another layer of cotton. So adequate cotton padding is very important and essential component of a good casting technique. Here a 6-inch POP bandage is being applied over the forearm. So here you can see that the cast, the below elbow POP cast, is being converted into an above elbow. So here, as we had already described, this is the supracondylar molding that is being done, and it is an important step in a good casting for the pediatric age group. So what I'll try to do is I'll just clean my gloves, and after cleaning my gloves in some water, I'll do the supracondylar molding. Here you can see I'm doing the supracondylar molding with the help of the thinner remnants and trying to evenly spread the cast across. So after that, I'll take the second 6-inch POP bandage, and I'm dipping it in water, squeezing the extra plaster, and I'll be applying it over the arm and around the elbow of the plaster. So this being the junctional area, it is technically a weak point, so we need to strengthen this area so that the cast doesn't break. So once this is done, our POP cast is complete, and again we'll just do the supracondylar molding of the plaster. So this is the above elbow POP cast that we have placed in mid-prone position, and after that we look for whether the patient is able to actively flex and extend all the fingers in the cast. After this, the patient was asked to get a check X-ray done after the close reduction, and this is the post reduction check X-ray, and it was showing an acceptable alignment, and you can appreciate the pre-reduction and the post-reduction lateral view, and wherein the apex volar angulation deformity has been corrected, as we can see. I hope you enjoyed the video, and if you did, kindly like, subscribe, share, comment. Thanks for watching.